Bismillahirrahmanirrahim. Quote of the day is difficult roads lead to beautiful destinations. My name is Dr. Aamna Khalid. I am PGR Community Medicine. Today I will be presenting the topic of epidemiology, public policy and ethics under the current supervision of Professor Dr. Saira Afzal, who is Dean Institute of Public Health Lahore. So these are the opening remarks that no man is an island means interconnectedness lies at the heart of epidemiology. Health and disease are not isolated events, they are shaped by social, environmental, and behavioral connections. Epidemiology therefore carries an inherent societal responsibility and ethical dimension. Why ethics matter? Epidemiology directly shapes public policy and clinical decision. Unlike um, many basic sciences, its findings often have immediate societal impact. Studies involve human participants who may not directly benefit from the research, and the research is commonly funded by public resources, raising accountability obligations. Um, it deals with the population level decisions that affect individuals and influences the allocation of limited health resources, requires a careful balance between individual rights and community benefit, and no other applied science has quite this combination of scale and immediacy. So the core ethical principles are autonomy, which means the respect for individual decision making and self-determination. The second one is beneficence, acting in the best interest of participants and society. And then we have non-maleficence. This is a duty to avoid causing harm to the participants, and justice, which is fair distribution of risks and benefits across the groups. What are the investigators' obligations to subjects? They must obtain informed consent wherever possible. Full disclosure may introduce response bias, so knowing the hypothesis can change behavior. Consent is in epidemiology is therefore often not perfectly fully informed. Core challenge in this thing is we have to balance between the scientific validity and the respect for autonomy. So the challenges related to informed consent are that subjects may alter the behavior when aware of the study hypothesis, introducing bias in the study findings. Many studies use existing records where prior consent was never obtained. Long-term studies may involve participants who are no longer traceable. Retrospective studies using administrative data face particular ethical scrutiny. Now we talk about confidentiality and privacy. Epidemiologists traditionally promise the absolute confidentiality. However, legal systems may introduce research data breaking that promise. Modern consent forms must explicitly state the limits of confidentiality, and the data breaches can cause serious social, financial, and reputational harm to participants. This is a case study about HIV and at, what ethical dilemmas are associated. The scenario is that HIV study participants were assured strict confidentiality, but some later donated blood, creating a risk to the recipients. So the ethical conflict is we have to protect the participant confidentiality as promised, versus we have to protect the recipients from potentially contaminated blood. So no perfect solution exists. This requires careful ethical judgment and case-by-case assessment. The next thing is communicating study results to the participants. Participants may request results even when findings are uncertain or not clinically actionable. Sharing the preliminary results can cause unnecessary anxiety. So beneficence, which is doing good, versus protecting harm from disclosure, the tension exists between these two things. The investigators must decide what, when, and how to share findings responsibly. So why data access matters? Because medical data is essential for generating valid epidemiological evidence. It enables the follow-up studies and longitudinal research, drives the public health policy resource decisions, links records from diverse sources for deeper insights. And why policy matters? Because data collection intrudes on personal privacy. Individuals may not have anticipated research uses. Risk of re-identification even in anonymized sets. Balance must be maintained at every stage of research. So using the medical records are used to identify cases and validate the data. Record linkage across databases enables incidence and mortality calculations. Without access to records, many important studies become impossible. Ethical safeguards must accompany every access request. So record linkage, epidemiological links, hospital records are interconnected to the employment data, and that's connected to the death certificates. The record linkage allows calculation of disease incidence and cause-specific mortality. It enables long-term cohort studies without repeated direct contact. And the ethical concerns are risk of de-identification increases as data sets are combined. Consent for linkage may not have been obtained at time of original data collection. So these are the methods for protecting confidentiality. We can use study ID numbers instead of names throughout the research process. Store identifying information separately under strict physical and digital security. The report only aggregate data in publications, never individual level identifiers. Destroy identifiers after study completion when no longer needed, and encrypt all data at rest and in transit. This is the legal framework. Regulations protect health information for privacy for individuals, allow data use without individual consent in certain defined circumstances like public health surveillance activities, research approved by the institutional review board. It demonstrates a structured balance between privacy rights and research needs. And similar frameworks exist internationally, like the national data protection laws are there. So the ethical conflict lies in the access to data, that who owns the data, either the patient or the institution or the funder, and who should be permitted to access it, and for what purposes. Should raw data or only summary statistics be shared publicly? Can data be misused by insurers, employers, or other third parties? And removing the identifiers may reduce scientific usefulness of the data. So data sharing has some key challenges like de-identification reduces the privacy risk, but can limit research utility. A full open data sharing risk privacy breaches despite anonymization attempts. Cost and legal responsibility for data sharing remain contested. International data transfer adds regulatory complexity, and the competing interests are between the open science and the participant board protection. The concept of race and ethnicity in epidemiology, when race can be useful, when it's widely used to study and document the health disparities, and it helps and identify high-risk groups for targeted interventions, can guide resource allocation and public health campaigns. It's useful when purpose is clearly defined and applied with caution. The limitations and risks associated with it are the race is socially constructed, not a precise biological category. Genetic variation is continuous, not categorical. It may lead to stigmatization of the groups, may act as a proxy for socioeconomic and lifestyle factors, and can divert attention from two causal pathways. So some questions rise before using race as a variable, that why is race being studied? What is the scientific or policy justification? How are racial or the ethnic groups being classified or by whom? Is race acting as a surrogate for another variable like geography or the access? Could the findings cause stigma or harm to the identified groups? Are findings contextualized to prevent misinterpretation? So we have to keep all of these things in mind. Next concept is conflict of interest in research. Conflict of interest can arise from the funding sources, including industry or the government sponsors. Institutional pressures to publish positive findings are there. It may affect the study design, choice of outcomes, data interpretation, and can influence whether and where findings are published. So, disclosure of conflicts is mandatory in peer-reviewed publication. Next thing is publication bias, which is also labeled as the silver blaze effect. So the scenario is that Holmes noted that the dog did not bark. So the missing evidence was itself the clue. The ethical conflict exists between the studies with null or unwanted results are never conducted or never published due to vested interest, versus the other thing, which is that this dog that didn't bark creates hidden systematic bias in the scientific literature. So the blaze effect is the absence of evidence is evidence. We just can't see it. Interpreting epidemiological findings, not all the reported risks are large, true, or reproducible. Single studies are rarely are providing definitive evidence, so replication is essential. Media often amplifies the unconfirmed or preliminary findings. The relative risk versus absolute risk must be clearly distinguished for the public. Confidence intervals and p-values can be misused or misinterpreted. Public misinterpretation of risk. The public may overreact to small absolute risks reported in dramatic terms. They may simultaneously ignore large, well-established risks like smoking. This leads to erosion of trust in scientific and public health authorities. So, media literacy and clear science communication are essential tools. So, one question arises at how many studies are enough to produce an evidence. So the answer is a single study does not constitute the proof. Replication across different populations and settings is required. Consistency of findings across study design strengthen the evidence. Biological plausibility must support the statistical association. Systematic reviews and meta-analysis consolidate the evidence base. So, what epidemiology contributes? It informs the laws and regulations, guides design of health programs, drives resource allocation decisions, provides the evidence base for screening guidelines, shapes international health agreements. And what else shapes the policy? Policy decisions are also depend on the economics and cost effectiveness. Political will and feasibility also matter. Public opinion and acceptance are critical. Ethical acceptability varies across cultures. Epidemiologists must communicate uncertainty honestly. Ethical balance in public in policy decisions. Policies must balance individual rights against community protection, like vaccination mandates are that protecting herd immunity versus bodily autonomy. We have to consider both of them. And other example is quarantine orders. We have to consider the infectious disease control and the freedom of movement at the same time. For the example of population screening, early detection benefits versus the overdiagnosis harms, we have to balance between the two. So each decision involves trade-offs that epidemiology can inform but not resolve alone. So these are some of the current challenges in epidemiology and ethics. Big data and electronic medical records. There is unprecedented scale of personal data. Genetic and genomic information, sensitive, heritable, and difficult to anonymize this data. Artificial intelligence in research, this can introduce bias amplification and explainability gaps. Data security threats like ransomware breaches and unauthorized access, and globalization, which includes cross-border research, which raises the jurisdiction and consent issues. So to summarize the whole thing, epidemiology is deeply and separably linked with ethics and public policy. Ethical dilemmas arise at every stage, at the stage of consent, privacy, data use, and interpretation. Core principles are autonomy, beneficence, non-maleficence, and justice. Race or ethnicity must be used with clear purpose, caution, and contextual awareness. Conflict of interest and publication bias silently shape the evidence base. So now we come to the MCQs. Question number one is an investigator uses hospital records from 10 years ago without prior consent to study diseased veterans. What is the main ethical concern? Option A, autonomy. B, justice, C, beneficence, D, non-maleficence, and E, random error. Option A is the right answer. Question number 2 is researchers identify HIV positive individuals who had donated blood but promised confidentiality. So the best ethical conflict which can exist between two things is option A, justice versus autonomy. B, autonomy versus public safety. C, beneficence versus justice. D, bias versus confounding. And E, precision versus validity.
B.
Option B is the right answer, autonomy versus public safety. Question number 3 is a study finds a biomarker linked to cancer, but no treatment exists. Participants request results. The primary ethical issue exists in option A, justice, B, autonomy, C, beneficence versus harm, D, random error, and E, external validity.
C.
Yes, C is the right answer.
C.
Question number 4 is a researcher links employment records with death certificates to study occupational cancer. The main ethical concern is option A, recall bias, B, privacy breach risk, C, confounding, D, measurement error, and E, selection bias. So B is the right answer. Question number 5. A dataset removes all names and identifies before analysis. This primarily protects option A, justice, B, autonomy, C, confidentiality, D, validity, E, precision.
C.
C.
Yes, C is the right answer. Question number 6. The study uses race to explain hypertension prevalence without considering socioeconomic status. The main problem exists in option A, confounding, B, selection bias, C, information bias, D, random error, and E, effect modification.
C. B.
Option A is the right answer. Question number 7. A study funded by a tobacco company reports no association between smoking and disease. The main concern is option A, random error, B, confounding, C, conflict of interest, D, selection bias, and E, external validity.
C.
Yes, right. Question number 8 is after study completion, another researcher requests raw data for reanalysis. The main ethical issue is option A, autonomy, B, data ownership and access, C, beneficence, D, random error, and E, internal validity.
B.
Yes, B is the right answer.
B.
Question number 9 is researchers analyze large EMR datasets without individual consent but with IRB approval. This is justified by option A, autonomy only, B, public health benefit, C, random error reduction, D, selection bias control, and E, measurement accuracy.
B.
Yes, B is the right answer.
B.
Question number 10, a screening
B.
test identifies many false positives causing anxiety. The ethical issue is option A, beneficence only, B, non-maleficence, C, justice, D, autonomy, and E, precision. So B is the right answer. This is the answer key. This is the YouTube channel of IPH where this presentation will be uploaded. Thank you.
Thank you so much, Dr. Aamna.